We'll go ahead and get started. My name is Scott Pleasant. I'm from the Virginia Maryland College of Veterinary Medicine at Virginia Tech, Blacksburg, Virginia. Did you guys hear Travis talk yesterday, Travis Burns? Okay, so he and I work together in the podiatry service at Virginia Tech, so there might be a smidge of overlap between our talks. What I want to do today is talk to you all about the benefits of using radiography with Farriery. I'm going to explain the views that would be most helpful to y'all and the parameters that you would evaluate from those views, and then we'll use examples to kind of illustrate those concepts. So my first question is just for the group. What would be reasons, benefits for you guys to use radiography to help your trimming or shoeing? Any examples? Okay, so somebody said a founder pony. Be a little more specific. How would it help you? Okay, so one, I think the suggestion was the laminitic founder pony. Let's just say chronic laminitis. That is one of the most common cases that we see at Virginia Tech, and we use radiography to help ourselves work with those horses. And we not only evaluate bone health in those horses, but position of the distal phalanx or coffin bone within the hoof capsule. Well, in these cases, alignment of the hoof capsule and the distal phalanx, because they're the ones that can get away from the farrier very easily because they don't grow like a normal foot. Okay, so very helpful. Any others? Okay, so mentioned center of rotation, sole depth, but to get a lot of parameters that may just help improve shoeing of an individual horse, where we use that is specifically in the lame horse, because we're always trying to fix something, do something a little bit better. So using the radiographs to help our farriers is very important. Okay, so sole depth would be one of those parameters that would be really important to us, really in a lot of different cases. You guys do a great job of judging that in your everyday life, but some of the more difficult cases, it can get away from you or be hard. Okay, any other? Okay. Baseline, that's a good idea to have baselines. It's been discussed that as part of wellness exams in horses, and Dr. Myers was mentioning it with his own personal horses, if you had a bank of when that horse was young and normal, what its feet were like, to come back and compare to, because whenever a horse gets in trouble, it is really nice to have that something to go back and say, okay, I see how it's changed. All right, so you'll see some practices actually put that in their wellness program, certain views of the feet, and then just bank them, just like blood work. Joint spacing, okay. So maybe the radiographs will help us evaluate joint spacing or joint angle to help us decide on balance or things like that. I will say, it's a little caveat, judging joint space can be really hard with radiographs, because we know that just a little bit of off positioning can alter it. So there's been a lot of times I think it's been misused or abused. Even just the horse leaning can really change a joint space. So if you're going to use it for that, you have to be really, really careful and really, really accurate. Palmar angle, again, that's another parameter that we use quite a bit. Okay, so I'll just list these for you. You've already mentioned the top one, evaluating hoof capsule, distal phalanx alignment. Again, I have the laminitis cases, but also our flexure deformities, which often have a mechanical type laminitis. Very important for us to try to help them. The lameness case, again, to evaluate their mechanics, that's all those parameters which you guys have been throwing out. Our cracks and our white line disease. Travis showed a few pictures yesterday about how the radiographs can highlight the amount of undermining and dissection, that's not apparent to the eye. And that's very helpful for us in treating those cases. The immediate feedback is great, because when we have a chronic laminitic or a lame horse that we're trying to fix, it's not uncommon, particularly for us, to have the pre-radiographs come up with the plan, trim them, re-radiograph them, and then do a little touch-up trim to that. Okay, so again, it's kind of given, it's not x-ray eyes for the farrier, but it's as close as we can get so that they can make those micro adjustments. To learn growth patterns, that's real important in those chronic laminitics, is again, the reason they get away from the farriers is they're just making slight miscalculations each trimming, and over time they get away from them. Once the farrier has a series of radiographs, they can kind of zoom in on that horse's growth patterns and then be able to trim them better. We talked about evaluating bone health. And last but not least, it's really important sometimes to illustrate to the owner the problem. Okay, helps them understand what's wrong, and then understand why we, the vet and the farrier, are going to do certain things. Okay, so again, if you can show them the amount of undermining on a radiograph that they can't see on the outside, they're better able to understand why you're going to take all this hoof off. Okay, I think we've all, sometimes when an owner's not been there or think they understand, take a bunch of hoof off, and then they're shocked when they come home. So having that visual to them is very helpful, and that discussion ahead of time is very helpful. Okay, a huge component of this is it makes the vet and farrier work together. Okay, and especially for the difficult cases, it puts two heads together. Usually you're coming to a consensus on about what's going to happen. Okay, rather than one person deciding or the other decided and one criticizing, one not. So putting us together, always usually two heads are better than one, and help the outcome, which is really what it's all about, helping the horse. Correct? The last I have highlighted in blue, farriers, I think you guys just need to, I know you do, but understand and emphasize to you that you're part of the healthcare team of this horse, right? And so if you have a difficult case or a case that's bothering you, you should have no hesitation asking an owner for radiographs to help you do the job that they're wanting you to do. Okay? We teach our vet students all the time is that, again, they're a component, the farrier's a component. They got to work together to help that horse. Right? There's lots of things that I ask other people to do to help me take care of a horse. I can't do an MRI by myself, so I ask for that. That helps me do things. You guys have every right to ask for radiographs to help you do your job. Okay, and vets should be willing to help you. Okay, so radiographic evaluation. We're just going to spend a little bit of time on this. At minimum, what we call podiatry views at Virginia Tech. Again, we just made that term up, but they're going to be a lateral, meaning from the side, and a dorsal palmar, meaning straight from the front views. Those are the minimum you would need as a farrier. Okay? You might want other views depending on what the problem is, but those would be the minimum. For those podiatry views, they're actually very specific. Okay? The vets that do a lot of podiatry work are going to understand this, but vets that don't are going to maybe have a difficult time giving you those views. So you might have to politely educate them on the views that you want. And the views that you want are going to help you evaluate, again, the position of the distal phalanx within the hoof capsule, balance, and a lot of these measurements that we're going to talk to you about. Okay? And where I'm going at it is the traditional vet lateral view of the foot. Do you know what that is? They're not really worried about those things. They're worried more about the navicular bone and the coffin joint. So it's centered higher, which distorts the views that are going to help you the most. Okay, so the podiatry views, again, always consistent technique, horse standing squarely on the blocks. And for you guys, we want to put the beam centered on the hoof wall about 1/2 to 3/4 of an inch above the bearing surface of the wall. Okay, we're trying to go right through the bottom of the coffin bone so that if we're looking through it, just like you would sight a horseshoe, you're going to see one plane. Okay, if we shoot up here, it's going to look unlevel as an artifact. Okay, and then we're going to evaluate parameters that you guys have already mentioned. We'll go over these. That's horn lamellar zone, HL, palmar angle, sole depth, digital breakover, basis support, medial to lateral balance. Okay, so here they are listed. Don't agonize over them. Okay, but they're just abbreviations. Right. So with any machine, the question was about technique, and that's obviously more for the veterinarian, but the distance from the machine to the cassette is important as far as causing distortion. So most machines have a recommendations, or vets have set up their machine for a certain distance, and it's important that you stay as close to those distances and angles as possible every time, or it's hard to compare one set of films to another. So that's why I say that consistent technique is really important. So this is the lateral view from the side. And again, this is where you may have to help the vets. So this is centered, about 1/2 to 3/4 an inch above the hoof wall, where I'm thinking the bottom of the coffin bone would be. If I thought that horse, if it was a saddlebred and had a lot of foot under it, I'm going to have to go higher and guess where the bone is. Again, it's from the bottom of the hoof wall, not the bottom of the shoe. Okay, so you're trying to guess where that coffin bone is. Where would the vet likely center a lateral if they were shooting for a coffin joint? Yeah, so it's going to be right in here. And in theory, if they're doing a perfect navicular shot, it'd be a smidge back and a smidge lower. Okay, so it needs to be appropriate. Generally, the widest part of the foot. Okay, and this is the type of view that you would get. So vets would say, oh, that's a bad view because it's oblique through the coffin joint, but that's not what you guys need. You're trying to evaluate sole depth, is the palmar angle, is the bottom of the bone level, and things like that. So that's an appropriate view. Again, here's all those little terms just drawn out. Now, we don't draw these out all the time. You can with the modern machines. But what I'd encourage you guys, when you're looking at a radiograph as a farrier, these are the things you're checking. Okay? And we'll go through them. So this horn lamellar zone is simply the distance from a point up just below the coronet, measured to a flat spot on the coffin bone. You can't come up here where the extensor process is, or it's going to be quite different. But we try to find the flat plane, and then again we come down here toward the bottom and measure the same. All right. Now again, we all know coffin bones aren't perfectly flat or straight, so you can't get hung up in all the little variances in them. And you don't need to make this any more complicated than it needs to be. But what we want to see is that those lines are basically the same, the distances. And what that tells us is what you learned yesterday, is that basically the front of the coffin bone should be parallel to the front of the hoof wall. Okay. Now sometimes we'll actually use those measurements, particularly changes or enlargements, with our laminitis cases. Okay. There's a fair amount of variation in individual horses and what those normal distances are. But what we know, for example, when a horse gets laminar swelling, or edema in the lamellar region, that would increase. Okay, that fluid pressure is pushing the bone away from the hoof wall. Or if they rotate or move, then the lower measurement's going to increase above the top one. Okay. The blue is our palmar angle. And again, Mr. Nunn went over that very well. We tend to talk about it as being normal anywhere from 0 to 8 degrees. There's no science behind that. That's just kind of our thoughts. And most commonly, probably we would like them to be 3 to 5 degrees. Right? And again, you can measure that, or you can just look at it and say, I think that's appropriate. So we're looking at the palmar angle of the coffin bone. The red would be what we call sole depth, measured from the dorsal distal tip of the distal phalanx to the ground surface. So a little bit of a misnomer because it's going to include the keratinized sole plus whatever cup or airspace. It's not just the sole. So it's actually including it's the dermis, the hard sole, and the cup. Okay. Again, and that why we care about that is because that's protection on the bottom of the horse's foot. The green here, the average, so it's going to vary obviously between horses, but what we would use for the average, sport type, pleasure type horse is after we trim it, we would like it to be around 15 millimeters, but in all reality, a lot of times it's like 12 to 15. Okay, you start getting less than that 12 and they can get sore. Okay, some horses are trimmed, our barefoot horses, we'd like a minimum of 15, up to that 18 to 20 millimeters is awesome. Putting some barium on it. If you were just measuring true hard sole, yes, you could do that. So again, that sole depth is a little misnomer because it's actually the dermis, the epidermis, and then the cup. True sole thickness is kind of hard because if you have a concave foot, you're radiographing across something that arcs. So it's not you can't get an exact thickness of it, but no, to the ground surface of the foot. So it'd be to the shoe if they have a shoe on. Yeah. And it's just I would encourage you, again, some of us, do lots of measurements and calculations. What I'm trying to do is just give you basic visuals to look at. Okay. This green at the bottom is what we call base support. Again, this has been discussed a lot in the meeting where we would kind of like 50% of the shoe in front of the center of rotation and 50% behind. Okay, so we'll talk more about that in a little bit. And then the purple just is a term that we use as digital breakover. It's just given an indication of how much lever is in front of the distal part of the distal phalanx. So just keep those in mind, and we'll highlight them in a minute. Any questions on those? Okay. I will say before I go too much further, when there is mechanics in the shoe, like let's say this one has a roll, then we will give the horse the benefit of that and move digital breakover from that point of the roll as well as basis support. Okay. And again, this is just an illustration of drawing those lines. Again, you don't need to draw them on the radiograph. You should be able to draw them in the head. We're giving this horse his roll, so his basis support's here, center of rotation, dropping a line down, and then you guys from where you are could say, is that 50-50 or is it a little off, that kind of thing. But that's the kind of lines we're drawing. Okay, for that DP or the front to back, again, same thing, 3/4 of an inch above the hoof wall. Okay, straight through. And what we're trying to do is sight right through the bottom of that coffin bone. And this is how we can judge medial to lateral balance the best. You can draw the lines. Again, obviously anybody in here could make a degree or two different. We're not really worried about that. I'm not going to argue about that. It's just to help you say, okay, it looks pretty balanced to the ground, standing, loading P3 appropriate. All right, any questions on those? All right, now we're going to try to run through a few cases just to highlight how you could use this information to help you trim and shoe horses. So first one, It's going to be a 10-year-old warm blood. It might be, what's your name? David. So I say, hey, David, I got called and saw one of your clients last week. His name was, let's just say, I know this horse, so it's Corazon. He went to a show, threw his rider, jumped out of the arena, ran loose through the showgrounds for about an hour, and they finally caught him. Once they caught him, he was lame on his left front. Never had a problem before. They brought him home, rested him, and he's still lame. So they called us out on our physical exam. We found broken back hoof pastern axes and underrun heel conformation on his left and right front feet, but we couldn't elicit any other kind of pain or swellings anywhere else. We watched the horse go in a straight line. He was lame on the left front at the trot. When we circled him to the left, he got lamer. Okay. We went ahead and did a Palmar digital nerve block. That's the nerve block that isolates the foot. Okay. When we did that, the left front lameness resolved. Okay. And again, whenever we block a foot, we always are wondering, is it going to shift? And this horse, it did not shift. So it was left front lameness that we isolated to the foot. Based on that, we went ahead and radiographed the foot. We knew David would want the podiatry views, so we took them. So we took that lateral in DP, centered on the distal border of the distal phalanx, but then we also took a lateral and a 65-degree DP and a flexor view of the navicular bone because we're just naturally worried about it. Okay, so here's that first podiatry view. Centered here, looks like a good view. What do you guys notice on that one from your, just those lines that we drew for farriers? Okay, so, again, pretty flat palmar angle. Okay, so again, you probably could say, okay, I can see what Dr. Pleasant said. He is broken back. So he's got an extended, coffin joint. Yeah, so we believe that that's a stressor, strainer on the navicular apparatus. Okay, so those two. Is he aligned up front? Is he matched here? Looks pretty good. How about sole depth? Yeah, so again, when you're looking, you can't really see, but these machines do have an internal marker, and that's probably 15, maybe 18 millimeters. So what that should say to you is I don't have a lot of foot to work with on this horse. Okay, you could say maybe his toes pushed out a little bit. Okay, but those are the things you should be thinking of. So there they are. And that highlights that broken back hoof pastern conformation, flat palmar angle. How's his base of support? So he looks like we would call that, when he's got more foot in front of that center of rotation, a forward base of support. Okay, forward base of support. So those are the things you're kind of looking at while Dr. Pleasant and you are looking at these. Okay, here's your podiatry view, your DP. Okay, you can draw your lines, and you could argue maybe he's slightly high on the lateral side, or maybe he's flat. This, we know the markers, this is the outside of the foot. Okay, but nothing horrible. Okay, now again, what we've done is we've stepped up and shot up here. And so this is where I'm going to say, his navicular bone's a little misshapen. This is where the vet's going to hedge. This is that 65-degree DP. That's our navicular bone. And I could say there's kind of some modeling of that navicular bone, some mild modeling, maybe a mild increase in size or irregularity of those navicular bone distal border foramina. This is our flexor view, where we're shooting down the back of the navicular bone. This is the surface where the deep digital flexor opposes, and that's very nice in this horse. We can look at the inside of the bone, and I can see those foramina, and I might comment there's a little bit of sclerosis or reduced corticomedullary distinction in this horse. So I've done a little hedging on the navicular bone, but I haven't said anything really specific. So again, what did we see? We saw the conformation abnormalities. There's some mild navicular abnormalities, but nothing I can jump up and down and say that's the cause of this horse's lameness. The flexor view of the navicular bone and a navicular sky line are the same thing, correct? And there's a real big long name that I'm not even going to try to pronounce. So based on us not coming to a conclusive diagnosis, the horse was expensive enough and the owners wanted to dig deeper, so they did an MRI. And again, not going to dwell on this, but it appears the horse has, had a little tear in his deep digital flexor tendon just above the navicular bone. So based on that, we, the vets, are going to institute a lot of different medical therapies for this horse, but we're going to ask you, David, to trim and shoe this horse to reduce stress and strain on his deep digital flexor tendon. All right. So again, what you had was this to start with, and you got to say, what can I do to help this horse? So you guys want to comment? David, you can, or we'll take audience. Okay, so here's some wedges. So increases palmar angle. Purpose of that is to relieve some of that tension on the deep digital flexor tendon. It'll improve his hoof pastern axis. Okay, so moving the breakover back. Okay, good. So remember, whenever we pick a shoeing protocol, trimming shoeing protocol, there's not really a right or wrong answer. You guys just have to say what is wrong. That's what we would encourage the farriers to learn. It's like, okay, Dr. Pleasant says he's dinged his deep digital flexor tendon. How can I help relieve some of that stress and strain on that tendon while it heals? And so this is what we did. Okay, you can argue plus or minus. We did decide to put a wedge on that horse because there wasn't enough foot to elevate it with just the trim. So we did put a wedge pad on. We did set the shoe back. Okay, and then we put some roll in that toe. Okay, and we also put what we call a heel plate with a Equipack to kind of support and float the heels. So don't worry about that. That you guys might have chose a different method. So we chose, that's a 3 degree, just to kind of go up that way, and we thought you might have got a little bit with the trim, Travis might have, and then went ahead and added the 3 degree and just see how we got. So again, this is given he and I instant feedback. This is right after shoeing, and we're like, okay, yeah, I think pretty happy with that. Went from that, to that. And we'll see how that goes with that horse. So again, does that make sense? And so that's where you guys would use that information to make the decisions. You might have chose a total different way, but probably the principles would be very similar, even if it was a different shoe or different way to get it done. Yeah, that horse specifically did not resent hoof testers, probably because the lesion was a little bit higher. Yeah, I'm guessing. Yeah, those are the kind of things that MRI has just really helped us, because in the old days that horse didn't respond to point pressure. He was just lame, and obviously he did something when he jumped out and ran around, hurt himself. Okay, so there's our after lines, and you guys, we, meaning, or you, if you did it, say, okay, I'm good with that, or I'm not, or maybe next time I can do it a little different, a little bit better. So that's the feedback. Okay, any questions on that one? Okay, next one. It's an 18-year-old Arab mare. She's a retired brood mare. She had a history of a pretty marked bout of laminitis 3 years ago. She'd been doing well, but recently she's gotten lame after she's been trimmed, specifically the last 3 times. The first 2 times she got over it in a couple weeks, and this last time she's maintained lameness. So this is her foot. Okay, anybody want to comment, or what can you tell? Do what? Yeah, she hadn't been radiographed since her laminitis 3 years ago. So my question would be, why would you think she might become lame after getting trimmed? Give me some reasons. So lack of vertical depth, sole depth. Yeah, could be. So could it be trimmed too short? She's just not happy that way. If her heels get cut too much and it pulls on her deep too much, it may pull on her weakened lamellae, and that may hurt her. She was rotated 3 years ago and then got back to normal, but then hadn't been done. So, you guys are giving a lot of answers. The good news, bad news, there's a lot of reasons this mare could get sore, right? And so this is her lateral. All right. And so now why do you think she got sore? So that's, yeah, so go, yeah, so this one, it's malalignment of the distal phalanx and hoof capsule. You'd have to really look and make sure this mare wasn't actively laminitis, but this was just trimming that got away from the farrier. And so how would this horse grow? If you back up and look at her, how's she growing? She's growing at least twice as much heel as she is toe, right? So she's doing that. And so every time the farrier trims her, they give their best guess about how much heel do I take versus toe. But if you're a degree off, over a year or two, then the heel gets long, and if you trim from the bottom, they get shorter and shorter under the tip of the distal phalanx. So this one just happened from not taking enough heel and not taking enough off the front, but getting them short there. So she gets sore because she has no sole depth. That's what it is. But again, you could easily hurt a horse like this by taking a bunch of heel at one time, and they don't like it. But this one indicates it was from lack of depth. And that big lever probably doesn't make her happy either. Yeah, so the comment was just evaluating the growth rings, but again, we would all imagine this ring, came out of the cornet about the same time, and they're jamming, crunching in the toe, and it's growing what we'd call normal at the heel and abnormally at the toe. And that's how those, you've all seen the old founder pony that curls up, and everybody thinks it's their toe that's just taken off, and it's not. It's just getting crunched and pushed up as a result of that abnormal growth heel relative to toe is probably the best way to put it. Okay. So, again, what would you do with this one, just as curiosity? Yeah. So, again, I'll just say we've learned the hard way. Be really careful with these because you never know quite what's going on with them. And you don't want to be the big hero and take all that off and all that off and then the bone fall through the bottom. Okay, so again, what we chose with this one is just to do a light trim, touch the heels down, dress back the front, but this mare was sore enough at this time, we weren't going to push it, and so she was put in, the closed cell foam pads and soft rides until she got comfortable. Then we started using radiographs to guide the trimming and shoeing to where, within 6 months she's like this, and then she's very happy because she's loading P3 in a much more appropriate way. She still, has a chronic laminitic foot, but she's much happier this way than she was that way. Okay? And so what we would say is, if you have a horse like this, that's the ones, the farriers, man, you can't be this, X-ray vision person and know all this stuff. You have every right to say, twice a year I need this horse radiographed to make sure we're going in the right direction. And the owners need to give you that. Okay? If you needed it 4 times a year, you do it. Okay, twice a year, if you're like, okay, I got this, then you might go to once a year. But what happens when you start feeling too good about it, it comes back to haunt you, in my experience. No, she didn't. So she actually, you can imagine, she got like this, was feeling good, so they're like, oh, we'd like to start riding her. So she got put in some shoes, but like most laminitis, that was 211, and we put her down last year because, like it or not, the owners let go and things drift, and she had other bouts of laminitis. She actually was euthanized for colic, but her feet weren't great, I'm going to admit it. No fault of the farriers, it was the owners. So questions on that one? Yeah, so the comment was, it looks like she has a flexion of that. And so I think that's more of like a chronic, it's almost like a club foot at that time. She's been up that way for so long, that's just the way she's standing. So when you start letting that heel down, you got to do it carefully, because you're creating a tug of war between the deep and the weakened lamellae. And the deep will always win that war. So some horses, like she did, will let you go perfectly flat. Other ones, you're going to find what we call their happy spot, where that's as low as they're going to go. But we know P3 doesn't like to be loaded point down. It really likes that bigger surface area to stand on. So we get them as flat as they will stay comfortable. And we know every time, there's no doubt, I guess I don't want to get up here and make you think, this is after a trim. What do you think she's like in 6 to 8 weeks? She'll go up, and then that's why you guys learning that growth pattern, you learn, okay, I got to take this much more heel than toe. And a lot of these horses, you never take their toe except from the front. Yeah. Do what? That time frame was probably 4 to 6 months. 2-4, what's that say? 2-4? And that was 8. So August to February, 6 months. Yeah, the question was, could you put them, before you trimmed them, put them on a reverse wedge to make sure you didn't go, oh crap, I took too much. And we have done that, but usually we don't. Sometimes have we had to re-wedge them up because we took too much, certainly. But it's not a bad idea to do that. Okay, so the question was, do you do a deep digital flexor tenotomy on many of these? We don't, if we can maintain them, with normal, what I'd call wellness, healthcare, trimming, shoeing. If these chronic ones, if you end up having to cut the tendon, our experience is usually they only last about a year, and then they end up starting to contract again. So have we? Yes. Do we want to? No. And again, in our area, most people still really don't want to do tenotomies because they're mainly, at this point, she's a pet. Okay, so next one. 10-year-old thoroughbred gelding presented for evaluation of refractory white line. This is one Travis kind of went over yesterday. Again, a very common defect. Farrier's been kind of notching out, trying to clean up, but it just doesn't go away. Radiographed it, and you can highlight how much higher that goes. Okay, so here's the notching. Now we see this lucency going right up the wall to show it's at least twice that high. All right, so now with confidence you can tell the owner, we need to get all that off. That's the only way this is going to get better. We've been trying it conservatively. Okay, and they usually accept that better than if they just came home and that's what their foot looked like. Okay, some of you guys, your clients will let you do that, but others are going to be stunned or shocked and call Dr. Pleasant and say, I can't believe what my farrier did. Okay, so having that information supports what you want to do. Okay, and that's very important. Here's another one presented for white line disease they haven't just been able to get rid of. And this is funny when Travis and I laugh about it all the time because he was ready to pull the shoe off and clean the foot up, And I'm like, wait, leave the shoe on because I want it as a reference in the radiographs. The metal is often a good border. So here it is from the bottom. There's our radiograph. So when we took that, this horse walked in fine. Just walked right in. So we both like gasped and like, I'm glad we didn't put a knife on that foot. All right. So this is a severe white line disease. I don't think he got to this one yesterday, that has just become so extensive it destabilized. It's not a laminitis. That's why it could walk in like that. But it's lost the structural connection. The lamellae are fine, but it's just collapsed. Okay, so again, the radiograph would surely highlight to the owner how bad that is, right? And would be very helpful in illustrating to them what needs to be done and how difficult this is going to be. That one was basically resected. Everything that was bad came off, and of course there was nothing left to attach a shoe to, so it was put in a soft ride boot, and the owner treated it until it grew enough heel that we could actually glue a shoe on, but then grew out. Okay, so, but you're likely going to make that horse sore by taking all that off. Okay, so there is dermis covering P3. Remember, when you're looking at this lateral radiograph, it's just like a two-dimensional shot. What some of that lucency you're seeing, it's where it's going around the sides. Okay. Well, that horse really, it did sink, but it wasn't like a laminitis sinking. No, but it was an unstable foot that kind of, lost its congruity between its distal phalanx and the hoof wall. It just lost it. For those of you that were in here with Travis, where did it lose its structural? In that non-pigmented stratum medium, right? So that's outside of the lamellar zone. So that's why these horses can do that, and that's why they can recover and grow a normal foot. If that was a true laminitis, it would be devastating. Okay. Case 4. 12-year-old Tennessee walking horse gelding. It's had 3 subsolar abscesses in the last year. Okay. This is his foot. It's already been cleaned up. Here's the bottom of it. So you can see where, the farrier and the vet have been working, opening up these abscesses, kind of one of those multiple layered sole horses, but there's still pus coming from deep. Okay, a little closer view, just to test you guys. What's the pink? Okay, it's Play-Doh. It means we radiographed it. Forgot to take a picture till after the radiograph. So what do you think? How would radiographs help you? You guys, owners pressure you to do subsolar abscesses all the time, whether they should or shouldn't. Now it's like 3 times. Something's not right? Okay, so infection of the coffin bone, septic osteitis is a possibility. Okay, so I will say this horse walked in fine. Still, sometimes the septic bones, if they're draining, they can be pretty happy. So thoughts. We're going to go ahead and radiograph it. Here's our lateral view. So you see where it's been opened. You can even see a little undermining. Anybody? So again, we always tell vet students, if you're not sure, just keep your mouth shut. Don't look like a fool. So DP view. Okay, so here a keratoma. So why a keratoma? See this thing right here, that lucency? And when we say lucent, again, you guys, I encourage you to try to learn. That means loss of, like a lack of density. So, which in a radiograph, the bone, because it's dense, shows up white. So we'd call lucent that blacker area. So something there, what is that? I don't, take another view and there you go. So that something, it's a perfect defect in the coffin bone. Beautiful, well circumscribed, doesn't look like an infectious process. And so what we know that history and that radiographic appearance is classic for a keratoma. And what the keratoma is, it's a benign tumor of the keratin producing cells. Essentially they'll produce almost hoof wall-like material on the inside of the hoof. And it can get very big. If it gets big enough and it presses on the distal phalanx, that bone resorbs. Okay. The bad news, when the keratoma, that's a bad enough problem, but when it gets to the ground surface, it's a poor junction between sole and wall, so dirt and debris kind of work in it, around it, and that helps, that is a risk factor for abscesses. The bone never comes back. So this is that horse's keratoma. This would be up at the coronet. This is hoof wall. That's the bottom surface that we were looking at. Here's our epidermal lamellae, and then there's the big mass of keratin that's on the inside of the hoof wall. Okay, this is looking at it from the side. So outer hoof wall, coronet up here, ground surface. Here's our pigmented stratum medium, non-pigmented, and there's that big mass that shouldn't be there. Okay. Looking at it from the top, coronet. Here's our epidermal lamellae. You can see the little tubules where the papules from the coronary corium go in. And here's our keratoma, and if you notice, here's the little origin of it coming right up here. So it just starts there and then comes down and just keeps getting bigger. That one I just call just a tumor, and we presume that wherever they started, whatever, we don't know why or what, but one abnormal cell, and then it multiplies and multiplies, and they get bigger and bigger and bigger, and they just get pulled down with the hoof that they're attached to. All right. You can see them in the sole, okay, but the wall ones start, what I believe most of them start right up at the top, and then they just get bigger as they go down. So again, that's more of a gee whiz thing, but if you get stuck with one of those recurrent abscesses, don't just do your podiatry views, get those extra views. Okay. All right. We have like 10 more minutes. Do you guys want to ask questions or want me to keep going? Was it what? Oh, no, that horse is perfectly fine. I'm not going to go through the surgery of it, but the good news is because they come from the hoof, they usually peel out perfectly, and then you just basically have a big hoof wall avulsion that you treat. Now, yeah, that one I could see when you say it's so big, could it ever break? I've never heard of one breaking, and that horse did fine. The question was, why doesn't the coffin bone fill in? I don't know exactly, but I guess there's no real stimulus for it to do that. Like if it was fractured and heal, but to reconform. Good question. Okay, 8-year-old quarter horse gelding, acute onset of left front lameness a week ago. Began draining at the coronet a couple days later. The owner didn't want to call the vet, so they called the farrier. And farrier comes out, says, they suspected an abscess, which we probably all would. Couldn't find one. So the farrier says, you need to get Dr. Pleasant to radiograph this horse. All right. So here's our foot. It's broke open here, draining. So here's our lateral view, side view. Again, just so you note, here's that swelling, where it's popped out up here. That doesn't tell you a whole lot. You might see something, but we'll move on. So here's the DP. Okay. And I'll admit, once I took that one and I saw that line there, I'm like, does this horse have a toe crack? And I went around, because a toe crack might look like that because you're looking through, and I looked back at the front and there was nothing. I look at the heels and there was nothing, so I'm like, and then take a 65-degree DP. So this horse got his foot caught in something, somehow just blew apart. P3 must have had enough bleeding inside the hoof capsule that's why it popped out at the top and drained, okay, but stayed lame, obviously, and the farrier couldn't find an abscess. So again, if you get stuck in that situation, just bail and tell them to call the vet. Okay. And so again, with that, then we used all that information to work on a therapeutic plan to how to get that to heal with our farrier. So important to know the problem, where sometimes it's unfortunate. You'll see horses that go weeks upon weeks or even months like that before people will go ahead and figure out what's wrong with them. That question was, would that turn into a sequestrum? No. I mean, it's a small one. It's pretty rare that a horse would get a sequestrum from a fracture unless they're tiny. They have so much blood supply, they do a pretty good job of keeping them alive and viable. All right, so I'm throwing a couple outliers at you, but I think they're important because if you see this, you want to know. 4-month-old quarter horse filly. Farrier's concerned about the filly developing an upright foot conformation and requested, radiographs. They're on top of it to help them, decide how to trim this thing. So here it is, 4-month-old filly, starting to get that little, clubby look to her. All right. Radiographs show, a little bit of prying down here, maybe a little upright conformation. In this one, I'll just say it, lesson learned from me. I was with the student, and I was packing up everything now, and they're like, well, Dr. Pleasant, aren't you going to take the other views? And I'm like, what do you mean? I got what I need. And they're like, well, Dr. Moon, our radiologist, says you always got to take blankety-blank views. I'm like, okay, if you want to take the other views, take them. So they took them, and this filly has a fractured P3. And I'm like, wow, okay. A lesson learned from me. So no more flexure deformities or sore-footed foals without doing that. In fact, this led to a study we did at Virginia Tech, and we followed 20 of our warm-blood foals from a week of birth to over a year of age. 95% of them fractured their coffin bones. 19. And some of them were lame, and some of them never were lame. Just running around on those little immature bones. I think somebody showed how weak those things are, and I guess just running and playing and doing full stuff. And the good news is, in probably 4 months, there's not a person in here who could tell that filly ever had a fracture. Okay. It healed perfectly, and the foot came back to normal. Yeah. So me being a surgeon is like thinking back, how many foals have I operated on that had that? Because we just looked at their foot. And then, those of us who were radical started taking the lateral view and then never thought to take that view. So, don't know. That's what I'm saying. And I may have been part of that. Now, I can tell you, there's a bunch of them that I know, like the year before on the same farm, that we treated, looked for abscesses and couldn't find them. So we said they just bruised their foot, and they eventually got better. And so they were probably, a lot of them, these things. So, they were in a typical, broodmare farm. So parts of it were hard, parts of it were nice, but they were foals. So, and that's been substantiated by studies in Kentucky that the thoroughbreds, have a high incidence that are just unknown. So I think we're done.